This is Pick Your Poison. I'm Dr. JP, ER doctor, toxicologist, and unapologetic lover of all things poison. Want to know what toxin can cause the brain to lose its brakes? What happens when antiepileptics don't work to stop a seizure? And why the nurse might have to give 50 vials of an antidote? Stay right here to find out. This is an interactive story. Survival isn't guaranteed. Will our patient live or die? It's up to you and the choices you make. Come with me and let's step into the emergency department. The charge nurse asks you to see the patient in room 7, saying she doesn't look great and is acting like she's drunk. You look at the computer and see that the patient's age is 13. A drunk 13-year-old? Anything is possible in the emergency department, of course, but this seems a little unusual. In the room, the patient is lying on the stretcher. She opens her eyes when you say her name, but she doesn't do much else. Her dad is pacing around the room, but stops when you enter. They speak Indonesian, so you get an interpreter on the phone. The parents say the patient was fine this morning. In fact, she seemed completely fine until about 2 or 3 hours ago when she started complaining of dizziness and vomited several times. She's having difficulty walking. She lay down to take a nap, and when they checked on her, they could barely wake her up. She hasn't had a fever, no headache, no cough or cold symptoms. She wasn't complaining of abdominal pain or anything else. The parents say she has a history of asthma, takes medicine for her lungs, but is otherwise healthy. They say she doesn't use tobacco or drugs and are adamant that she doesn't drink, nor is there any alcohol in the house as they are strict Muslims. The patient is doing well in school, getting straight A's, which they're especially proud of because they recently immigrated and she initially struggled with the language barrier. No one else is sick at home. The patient has a temperature of 98.5 Fahrenheit or 37 Celsius, a heart rate of 125 beats per minute. Her respiratory rate is 20 breaths per minute, with a blood pressure of 110/80 and an oxygen saturation of 100% on room air. She's a pediatric patient, 13 as I mentioned, so what do we think about these vital signs? She's afebrile, obviously. Her blood pressure is on the low side, but she's a thin teenager, so this is probably normal for her. Her heart rate, however, is a little fast. Her breathing and her oxygenation are good. On exam, she's lethargic and minimally engaged. She is following simple commands, but inconsistently, answers only enough to state her name, and her speech is noticeably slurred. Her cranial nerves are normal, her pupils are equal, round, and reactive to light, her neck is supple. Other than the mildly elevated heart rate, her heart and lungs are clear, she has no abdominal tenderness, and is moving all of her extremities with normal reflexes. There are no external signs of trauma. To sum up, other than the slurred speech, there's really nothing at all remarkable on the exam, until you ask her to give a urine specimen. She sits up on the stretcher with her mother's assistance. You notice her torso moving back and forth like she's sitting on a boat moving up and down in choppy water. Except, of course, the stretcher isn't moving. This is called ataxia, when you can't hold your trunk steady. Mom assists the patient to stand up, and it gets even worse. Her whole body is swaying, and she does look like a drunk person trying to walk on an unsteady boat. You grab the patient's arm and assist her back to bed so she doesn't fall. Question number 1. This could be A. Alcohol intoxication, B. Low blood sugar, C. A brain tumor, D. All of the above. The answer is D. All of the above could cause these symptoms. Do you think she's drunk? She does look intoxicated with slurred speech and altered mental status and ataxia. I'd send an alcohol level for sure. That said, a 13-year-old straight-A student who's been at home all day in a house with no alcohol, nothing again is impossible in the emergency department. This just doesn't seem like the most likely scenario. And I think it would be a big mistake to assume this was alcohol intoxication and stop your workup there. As I'm sure you know, alcohol intoxication is extremely super common in the emergency department, but it is also unfortunately fraught with pitfalls given the number of things that can mimic it, like low blood glucose, head injuries, infections, and that's just to name a few common things off the top of my head. So what else should we do to investigate here? A finger stick to check her blood glucose, basic labs. We've asked for the urine to make sure she doesn't have a urinary tract infection. I would order a head CT, though I suspect it's likely to be low yield. When you see people with slurred speech and ataxia, it often indicates a problem in the cerebellum, the part of the brain on the bottom near the brainstem. But it's not well visualized on CT scan, so it may not be that useful, but it is a relatively quick and non-invasive test that you can get in most emergency departments. It's probably a good idea to check and rule out anything obvious. You leave the room, order the workup, and move on to the next patient, an elderly man with a fall, while waiting for her results. Walking past her room on the way to his room, you hear her parents shout for help. You detour into the room and see that she's completely unconscious and all of her limbs are shaking violently. This is a generalized tonic-clonic seizure. The nurses come in to help. You order 2 milligrams of lorazepam, i.e. Ativan, a benzodiazepine to treat the seizure. Another nurse does a finger stick to check the blood sugar. It's 100 milligrams per deciliter, which is normal. The seizure stops quickly before the nurse can even administer the medicine. You ask her to expedite the head CT and to accompany the patient down on a monitor to radiology. As she gets the patient ready to go, you ask about the urine specimen. Negative, she says, no infection, pregnancy negative. She motions to the patient's breathing and asks if you want a chest x-ray. The patient is making some snoring sounds, and the nurse is worried she might have aspirated during the seizure. You say sure. The patient's labs come back in the meantime, noting that her bicarb is slightly low, meaning she's probably slightly acidotic, but nothing otherwise worrisome, no evidence of infection or electrolyte disturbances. The next thing we need to consider while she's going down to CT is whether or not to do a spinal tap. Could this be meningitis? She doesn't have a fever, a headache, or a stiff neck, so no, she doesn't have classic meningitis symptoms. Encephalitis is possible. You can have altered mental status and seizure without the other symptoms. But typically, patients have several days of symptoms like viral symptoms before becoming critically ill, but it is something to think about. Could this be new onset epilepsy? It's always difficult for us to know in the emergency department with a first-time seizure. You decide to talk to neurology about the case when the patient comes back from CT. You're in the room talking to the man about his fall when you hear code blue radiology, code blue radiology announced overhead. Question number 2. What do you do next? A, finish examining this man to make sure he's okay. The radiologist will handle the code. B, run down to radiology as fast as you can. The answer is B, run down to radiology. The radiologist will definitely not handle the cardiac arrest, and in most cases these days, they're reading studies from home. If there's any phrase that can make an ER doctor's blood run cold, I'll tell you this one is right up there at the top. Why? Because when anything happens in the radiology suite, it's usually complete chaos. They do have a code cart, the cart we have stocked with all the medicines for cardiac arrest, but they are not used to cardiac arrests, and it is not a good place to run a code. The best thing to do, get the patient back to the emergency department as soon as possible, where we are set up to handle these. Every time I hear this announced overhead, I run down my mental list of patients to see who I recently sent down there in case it's one of my patients. You apologize to the man, run down the back hall towards radiology, along with several of your colleagues and nurses, and burst into the radiology suite. Your patient is having another seizure in the CT scanner. Not great, but she's definitely alive and not in cardiac arrest. The CT tech panicked and called a code blue to get help. Fortunately, they were able to obtain the images before the seizure started. You and the nurses grab the sheet underneath the patient and yank her back onto the ED stretcher. You ask one of the nurses to go back to the emergency department and get the lorazepam out that you'd ordered previously. You and the other nurses roll her back to her room. One nurse administers the lorazepam, the others hook her up to the monitor, trying to get accurate vital signs. It's very difficult to do during a seizure for obvious reasons. They're never completely accurate, but the nurses tell you nothing seems to have changed significantly. A nurse applies an oxygen mask as a precaution as well. You give the lorazepam a few minutes to work. What happens? Nothing. Lorazepam, even given IV, doesn't work immediately, so it's always a knuckle-biting situation where you try to give it long enough to work while battling your natural instinct to call for 5 other things at the same time to try to stop the seizure. What happens if you give too much lorazepam? The side effect of benzodiazepines, as we've discussed many times before, is sedation. And what you really don't want to do is stack up a whole bunch of doses before the effects kick in. If you do, you'll find yourself in a situation where you'll have to intubate the patient and put them on the ventilator, even if the seizure stops, until the benzodiazepines wear off. On the other hand, though, we never want seizures to go on for any longer than necessary, so you have to try to balance the two. Mom looks horrified and Dad is crying. You ask if she's ever had a seizure before. They say no. You ask if there's any family history of seizures. Again, no. You check the clock. It's been a few minutes now. The seizure still hasn't stopped, so you order another second dose of lorazepam. Generally, we wait about 5 minutes between doses, though I can tell you when you're standing there with someone having a seizure, this feels more like 5 hours. Another 4 minutes slowly tick by. The seizure still hasn't stopped. Now you're starting to get worried. Seizures are common, epilepsy is common, febrile seizures in kids are very common, but these are all typically short and self-limited. Sometimes they do need a dose of medicine, but most of the time the seizures stop on their own. It's extremely upsetting for family members to see loved ones having seizures for obvious reasons, but giving a dose or two of anti-epileptics in the emergency department is really common. But if I give 2 doses and the patient hasn't stopped seizing, now I also start to get worried about status epilepticus because this is a true emergency. Do you know what a seizure is, actually? It's a sudden uncontrolled surge of electricity in the brain. Basically, your neurons start firing. Status epilepticus is when the neurons won't stop firing. Most seizures, as I said, are self-limited because your brain turns off the abnormal activity. But when it can't, that's a serious emergency. There are 2 main definitions of status epilepticus. The first is a seizure lasting for longer than 5 minutes. The second is having 2 seizures in a row without returning to your baseline mental status in between. It's common for patients after seizures, as we've said before, to have a postictal phase where they may be confused, agitated, or lethargic. It can last for minutes or hours, and they usually gradually wake up. But if you have a second seizure while still in the postictal phase, this is considered status epilepticus as well, because the brain really hasn't recovered before the second seizure happens. So this is status epilepticus. What do we do next? The main goal here is simple: make the seizure stop. Different hospitals have different protocols. There are differences between adult and pediatric protocols, but the general idea is simple. Keep giving medicines until the seizure stops and try to do so as quickly as possible. If 2 doses of benzodiazepines don't work, you could give a 3rd dose, or you could move on to an anti-epileptic drug, which is probably what I would do at this point. There aren't strict right or wrong answers. I'd give a loading dose of levetiracetam, i.e. Keppra, in the US. It's very effective for seizures, and the other benefit is that it doesn't have sedation as a side effect. The nurses give the Keppra, the patient is still seizing. This is getting really worrisome, and it's without a doubt a true emergency. Now what? It's definitely time to get some help from neurology. You call and ask for further recommendations. They lay out a strategy of additional anti-epileptics, which you order. This brings us to question number 3. This patient needs to be intubated. A, true, B, false. Every single time I have to make this decision about a patient in status epilepticus, I find it really, really difficult. I personally always feel like I failed to stop the seizures if I have to intubate them, though of course if I've gone down the status epilepticus protocol and treated the patient appropriately, it's obviously not my fault. Why is this difficult? Because there are several competing concerns. I don't want to intubate and ventilate a patient if the seizure is going to stop shortly, because they'll be stuck on the ventilator for probably a day or so, opening them up to infections and other risks. The other, even more serious problem is if we intubate a person, we lose the ability to know if they're still having a seizure or not. We're going to have to give a paralytic to be able to actually put the tube down into their airway. And after you give the paralytic, the tonic-clonic movements will stop. The patient's paralyzed, they can't move. But that doesn't mean the electrical discharge in their brain has stopped. It just means you can't see the seizure anymore. And then, if we don't treat the status epilepticus, we dramatically worsen the patient's outcome. Now, EEG monitors can tell you if the patient is still seizing, but in most places this is difficult to get in a timely fashion. And if we don't intubate, then they might aspirate and choke on their own secretions. You tell the intern and the respiratory therapist to get things set up. You ask the nurse to get the intubation medicines ready, but drag your feet hoping the seizures will stop if you give it a few more minutes. What's causing this? There are a lot of things that can cause status epilepticus, including epilepsy itself, underlying brain lesions, infections, endocrine disturbances. But as you know, this is a toxicology podcast, so let's not waste any more time and get right to toxins. I've mentioned before that many toxins can cause seizures, and the endpoint of many poisonings is often seizure, coma, and death. Status epilepticus, however, that's a much shorter list of toxins. Let's start with what we know the patient had access to. Her parents said she had asthma and took lung medicine. That might be albuterol, which we use in inhalers and breathing treatments. Occasionally, in a large overdose, albuterol can cause a seizure, but not status epilepticus. And as we go through the rest of the toxins, I'm going to focus specifically on status epilepticus rather than just a single seizure. You ask the parents what other medicines they have in the house. They say acetaminophen, i.e. Tylenol, and ibuprofen, i.e. Motrin. What about those? Nope, neither can cause status. The nurse says, "What now, doc? You've given the second anti-epileptic as recommended by the neurologist, and she's still seizing." Why do ER doctors and neurologists worry about status so much? First, the longer the seizure goes on, the harder it is to treat, leading to a vicious cycle. Morbidity and mortality rise sharply with the longer duration of the seizure. We know prolonged seizures result in brain damage, with some estimates that about 10% of survivors of status epilepticus will have a new neurological disability as a result. And actually, status can trigger multi-system organ failure, including cardiac arrhythmias and hemodynamic collapse. We talked already about aspiration. It can cause complete respiratory failure, hyperthermia from all the muscle activity resulting in rhabdomyolysis, i.e. muscle breakdown, which in turn can cause kidney failure. Even DIC, disseminated intravascular coagulation, resulting in both blood clotting and bleeding. The estimated mortality rate of status is about 16%, a number which hasn't improved since the 1990s. All right, the list of toxins causing status is relatively small, so let's try that angle. Sympathomimetics are at the top of the list: cocaine, methamphetamine, narcotics, especially tramadol, a pain medicine that specifically has a side effect of causing seizures. Another big cause in the emergency department is alcohol withdrawal, similarly benzodiazepine and baclofen withdrawal. Common medicines include bupropion, an older class of antidepressants, tricyclic antidepressants or TCAs, theophylline, a drug like caffeine occasionally used for asthma, local anesthetics we talked about before, antihistamines like diphenhydramine, i.e. Benadryl, pesticides like organophosphates. We previously talked about strychnine and tetanus, also water hemlock. In this patient, drug use and substance withdrawal don't seem that likely. The parents deny having any of those medicines in the house. They say there are no pesticides. They live in a city, so she probably hasn't been foraging. You ask the nurse at the computer to check to see if the radiologist read the head CT. He pulls it up and says it was negative. Good news, but it is not helping us get to the bottom of this case. He clicks on the chest x-ray and reads the report. Upper lobe lesion in the right lung, possible calcified granuloma. An upper lobe lesion on x-ray is classic for which of the following diseases? That's question number 4. Is it A, asthma, B, tuberculosis, C, silicosis, or D, lung cancer? The answer is B. Upper lobe lesions are a classic finding in tuberculosis, and a calcified granuloma could represent a previous tuberculosis infection. In asthma, you don't find significant x-ray changes. Silicosis, we talked about before, causes significant lung disease, but across the lungs, not localized. Lung cancer can cause a lesion anywhere, but especially in a 13-year-old girl, she's not that likely to have cancer. Also, as we noted, she's from Indonesia, and while you can certainly get tuberculosis anywhere, including the US, Indonesia has a high incidence of tuberculosis. This actually gives us a very important clue about what might be causing status epilepticus. You ask the parents if she's being treated for tuberculosis. They say yes, and that's the medicine she's taking for her lungs. Medicine for tuberculosis, not medicine for asthma. They don't know the name. You ask if anybody's at home to take a picture of the bottle. Unfortunately, no one else is there. What do we use to treat tuberculosis? Antibiotics. If you have active TB, you often need a multi-drug regimen, usually 4 drugs. Latent tuberculosis, which is consistent with a description on the x-ray, is when your body has fought off the active infection. The bacteria, while contained by the immune system, though, does still remain within the body. So the person isn't sick, they're not infectious, but there's a risk of reactivation in the future if they become immunocompromised or ill from something else like HIV, cancer, or another infection. In that case, the immune system might not be able to keep it contained, and it would essentially become active tuberculosis again. So the treatment to get rid of latent TB is 1 to 2 antibiotics, usually taken over several months. Now, different places have different treatment recommendations based on what's available, based on resistance patterns, etc. But it's time to pick your poison, and this is a tough one, really more for the medical professionals. No shame if you got it wrong. Is the antibiotic responsible for status epilepticus in our patient? That's question number 5. Is it A, ethambutol, B, rifampin, C, pyrazinamide, or D, isoniazid? The answer is D, isoniazid, or INH for short. Can definitely cause status epilepticus. The patient is still seizing. Does it feel like this seizure has been going on forever? Yeah, it does. Every time I have a case of status, I feel the same. Usually the family members are looking at me like, why aren't you making it stop? I'm wondering the same thing. Why aren't the drugs working? What could I be missing? All right, now we at least have a good guess as to what's going on. What's the treatment for INH-induced status epilepticus? The bad news is that antiepileptics don't work, but the good news is that we do have an antidote. And the antidote is actually a vitamin. Can you guess which one? That's question number 6. Is it A, vitamin B6, B, folate, C, vitamin C, or D, vitamin A? The answer is A, vitamin B6 or pyridoxine, and it works really amazingly well. As soon as you hear the chest x-ray results and think about tuberculosis as the patient's lung disease rather than her asthma, you order a dose of pyridoxine immediately. The standard dose is 80 milligrams per kilogram. Our patient weighs 50 kilos, so this would be 4 grams. The patient continues to have seizures, but rather than giving the medicine, there's a lot of discussion amongst the nurses and several calls to the pharmacy, which seems to be causing a delay. Finally, one of the nurses wheels over a metal Mayo stand and says, "Are you sure about this dose?" She points to the Mayo stand filled with pyridoxine vials. The entire stand is covered with the vials. 4 grams means 40 vials. Is that right? Are you sure? As a toxicologist, I love when the nurses double-check orders and doses with me for patient safety. And normally, if the nurse has to give 40 vials of something, you have ordered the wrong dose. Most medicines come in a vial within range of a normal standard dose. 4 milligrams of morphine is a common dose, and it comes in 4 milligram vials. Using pyridoxine as an antidote is a rare exception when giving many vials might be required, because it's usually given in the main hospital as a vitamin rather than the very, very large dose required for its use as an antidote. For example, a common size in pyridoxine is 100 milligram vials, and we need 4,000 milligrams or 4 grams. You confirm the dose with a nurse, make sure everybody's on the same page, and then several nurses help to pull up the medicine into several syringes to give it as quickly as possible. You hold your breath, hoping this works, because nothing else has been helping so far. What if we're wrong and this isn't an INH overdose? What'll happen? Nothing. There's actually no harm in giving a big dose of B6 once, even if it turns out to be unnecessary. And in fact, in some hospitals, pyridoxine is unofficially on the status epilepticus protocol in places with a high incidence of tuberculosis, because this scenario is actually not that uncommon. A minute ticks past, the patient is still seizing, another 30 seconds, and finally, the seizure stops. You and the entire team breathe a huge sigh of relief, and you know the nurses are cheering internally just like you are. We fortunately avoided intubation. The patient is barely conscious, but she is moving a little bit. This postictal phase is likely going to last for a long time, given how long the seizure lasted. She's admitted to the hospital for ongoing observation to make sure she wakes up and to make sure the seizures don't reoccur. Later that day, Dad goes home and brings back the lung medicine. The pediatrician texts you a picture, confirming it is isoniazid that the patient was prescribed. Why did she take so much, you ask? She's still postictal, the pediatrician texts back, meaning she's not awake enough to tell us yet. There are several fairly common routes of exposure. The first is unfortunately suicidal overdose, which is well documented in the medical literature. The family denies that she's been depressed. When the patient wakes up, she explains what happened. She says she missed her doses for a number of days and in order to make up for lost time, took a whole handful of pills at once. This is another common way people get INH overdoses. I've personally had a number of cases where this happened. This is a fictional case, as are all our cases to protect the innocent, but it is based on real poisonings. It highlights the dangers of missing pills and taking them all to quote-unquote catch up. If you do miss doses of your medicines, please get in touch with your physician for advice on what to do. If you take a handful of your blood pressure medicine, you might end up with dangerously low heart rate and dangerously low blood pressure. On the other hand, drugs like antiepileptics might require a higher loading dose to get your blood levels back to therapeutic, so please don't try to guess and do this on your own. How does isoniazid cause seizures? It interferes with pyridoxine metabolism, inhibiting an enzyme called pyridoxine phosphokinase. Without enough pyridoxine, GABA, one of the inhibitory neurotransmitters in your brain, can't be made. So if you run out of GABA, your brain becomes overstimulated with too many electrical impulses, i.e. status epilepticus. Wait a minute, did I hear you say, don't benzodiazepines also work on GABA? So why weren't they helping? Benzodiazepines do stimulate GABA receptors to open, causing sedation. But they require GABA to go through the channel to cause these effects. So if the benzodiazepines open the channel, but there's no GABA, nothing happens. Pyridoxine's action as an antidote is pretty simple. If you give pyridoxine back, you can restore GABA synthesis and normal GABA levels, stopping the seizure. We gave our patient a weight-based dose of pyridoxine and the seizure stopped. There is one potential pitfall with this approach. What is it? That's question number 7. Does the weight-based approach fail in A, patients with an enzyme deficiency, B, in pediatrics, C, in patients who also have epilepsy? The answer is actually B. You can run into some difficulty with the weight-based dosing of pyridoxine in very small patients. The actual ideal dose of the antidote is milligram per milligram for the amount of INH that the patient actually took. So if they took 10 grams, you want to give 10 grams of pyridoxine. So that's easy to do if you know how much the patient ingested, but the reality in the emergency department is that we often have no idea, so we do the weight-based approach to sort of guess. There's an interesting case report of a 10-month-old who stopped seizing after weight-based dosing of 650 milligrams of pyridoxine, but several hours later developed seizures again, which stopped after a second dose. Essentially, 650 milligrams was too low a dose because he was a little guy in comparison to what was ingested. So it's just something to keep in mind when you're taking care of very small patients. The other issue you can run into is that the hospital might not have enough pyridoxine. A 1-month supply of INH for an adult could be 10 grams, so as I said, you might need 10 grams of pyridoxine, but many hospitals don't have 50 vials of pyridoxine, for example, so that's another issue to be aware of. I had wondered before I did this episode how pyridoxine was discovered as an antidote for INH. When isoniazid was first discovered as an anti-tuberculosis agent, patients were treated with high doses which caused peripheral neuropathy, and clinical studies showed that pyridoxine helped without affecting its potency against tuberculosis. There's a book called The Black Angels about Black women working as nurses in 1929 at a large tuberculosis sanitarium in Staten Island, undertaking a difficult and dangerous job that nobody else wanted at a time when 1 in 7 people died of tuberculosis. These nurses played an important role in the clinical trials for isoniazid. I haven't read this book, but if you have, let me know if it's worth a read. And that brings us to the last question in today's podcast, a sort of historical pop culture question. Which of the following famous people died of tuberculosis? A. Eleanor Roosevelt, B. George Orwell, C. Anton Chekhov, D. Frida Kahlo. Follow the X and Instagram feeds both at PigPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pigpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.